everyone, it's good to see you again. Nice to have you back again for a second year. As you know, we're getting ready for our rotation with community health. And so today we're going to be talking about infection transmission and bag technique. It is very, very important right now, especially with the COVID crisis going on, that we know a little bit more about how things are transmitted and how to keep our frail population safe. For community health, some of you will be going into this right now for your next rotation. Some you're following rotation, but this is very, very apt and important to study about the bag technique, because the RNs that you will be following will be performing this and expecting you to be able to know this. So, infection transmission. About 2013 or so, there was a large-scale RCT that was performed on the rate of infection transmission pertaining to the health, public health nurses, home health nurses, and how they were transmitting between patients, and just how many multi-drug resistant organisms were being transferred to perhaps fresh post-op patients and our frail elderly patients, pediatric patients. So they, about 152 home care nurses were selected to take part. They were chosen by an outside resource, and 456 cultures were obtained from the outside and inside of their bags. Now, they knew ahead of time that they were going to be possibly chosen to be in the RCT, and so they were allowed to prep their bags and cleanse their bags. What the findings were pretty interesting, because the rate of contamination from outside the nursing bags, even after being cleansed, was 84%. Inside the bags is almost half, of 48.4%. And even worse, the multi-drug resistant organisms were found to be 15% on the outside of the nursing bags, and 6.3% rate inside the bags after being cleansed meticulously. So we're not catching these infections before we transmit them into the patient homes. Now with COVID, things have even changed up even far more importantly, that we follow the infection transmission protocol. So we're going to look at, through the framework of Betty Newman's systems theory, how we can impact our patients negatively when we bring in germs that can make them much sicker, and these frail elderly and post-op patients obtaining an infection is something from us, is something that we do not want. So our challenge is to look at that through systems. So Betty Newman believed that the human being is a total person, and it's a client system, a layered, multidimensional being. So the patient themselves has many layers that they're connected to within family, within social support systems, and then the nurse enters their lives, and that's another layer that adds to their multidimension. So the nurse is seen as the last line of defense for infection control. So if we look at it through that lens, we can see how important our role is to maintain the safety of our patients. So today we have a guest, and he's Ron Wallace. He's from the local public health department, and he's going to show us exactly how to do bag technique appropriately and a few things about infection transmission. There will be Q&A afterward, and then we will go on to do our practice for our checkoffs pertaining to bag technique. Mr. Wallace, could you come and address the students?
Hi, my name is Ron. I am a clinical manager for public health, and I have with me one of our nursing bags for home care. With public health, we do a couple things. We have not only the public health part of what we do, but we also do a home care component. With the new COVID guidelines and some of the new dynamics that we have to maintain good practice as far as making sure that our patients are safe. Prior to doing anything with entering the home and good bag technique, we have to formulate a schedule and decide the patients that we will see. Normally, if we have patients that have MRSA or COVID, we move those patients to the end of the day so that we do not compromise any of our weaker patients and those that are fragile. When we look at our bag technique, the goal is to make sure that we keep patients safe and to make sure that we are using good practices. With the bag, there is a dirty and clean side to the bag. Everything within the bag is the clean side, and we do not open the bag until we're ready to get into the bag. So when we go to a home, we've determined that it's safe for us to enter. Of course, we will use proper PPE. If we have somebody that has COVID, we will use the shields, the mask, gowns, gloves. We will also have our mask. Did I say mask? We'll have those. But when we enter the home, this is the dirty side of the bag. What we're going to have in there is hand sanitizer. We're going to have our barrier, and we have a barrier that is placed in such a way that we can place our bag on a flat surface. We never place our bag on the floor because, of course, if it does not have wheels on the bag, it does not need to be on the floor. So we have our barrier. On our barrier, I like to have the bag so that there is one side that is clean, one side that is dirty. We use our hand sanitizer. That is in the dirty side of the bag. The barrier is also on the dirty side of the bag. We friction until it is gone, until your hands are dry. As we open up our bag, we will remove the things that we are going to need for our assessment. That would be things such as a stethoscope, thermometer, blood pressure cuff, pulse oximeter. Those things will be used for our home care visit. After we have done the assessment, these items will go to the dirty side of the table. Nothing is ever reintroduced into the bag. After we've gotten what we need, we certainly close the bag. Nothing is reintroduced. I like to take a garbage bag with me so that I do not introduce anything. I place those items that I've used into that bag. I seal it up with any paperwork, anything that we would take out of the home. As we take these items to our vehicles, these items often are put into a dirty tote versus we also have a clean tote, but they are placed in the dirty tote to be sanitized and cleaned later. After we finish the assessment, also any labs that we would draw, such as blood, if we did a UA, if we did a stool sample, any of those things would also go into that dirty tote. Those things would then be taken before we go anywhere else, straight to the lab and where it would be processed. But this is certainly, there's more to clean bag technique than what I'm addressing here, but the main takeaway from this is that we understand that that we have to maintain good protocols so that we can keep our patients safe.
And then for PPE, what do you wear into the home for known COVID patients?
For known COVID patients, we will use a mask. We can use a face shield or goggles. We will use a gown, gloves. All of those items will be taken. We will use those items as we go into the home. We also have a specific kit that we take into the home. We have developed a protocol for COVID patients. Within that kit, we have, from some of the grants that we have received, we have a pulse oximeter that's dedicated to that patient. We have a thermometer. We have a stethoscope and a blood pressure cuff. The blood pressure cuff is color coded so that it stays with that patient until we are, if the patient improves and we are done with that patient, then that stuff can later be removed from the home, and then we can sanitize that stuff. But it is dedicated so that we're not taking our bag into the home. And as I said, we normally, typically, move those patients as far as a schedule at the end of the day, so that we're not compromising any of our fragile patients.
Awesome, thank you so much. Any questions, anyone? And we'll have a chance to talk to Mr. Wallace too later on as we do our check-off practice, and we'll do that for about a half hour, and then after that we'll be ready for our check-offs. Good luck, everyone.